got a great show, super interesting topic. We are going to be talking tonight about the role of how many IUI is reasonable, as yet unpublished study coming out in Reproductive Biomedicine Online. And hopefully it'll bring some insight into how far should we push this, how many times should we do things. I think that's an important topic. I do want to sort of have a shout out for our previous episode last week, which should be up soon. When do you think that's going up? Today, tomorrow? Yeah. So that was a great topic because it was how many live births will you achieve after how many embryo transfers. And they showed that if you have 3 genetically normal or euploid embryo transfers, you have a very good chance of achieving success in terms of your live birth rates. So I think that there is some very, very good hope for patients who are struggling and trying, and that there's a good opportunity there. The volume, I think, is being pushed by this because when I'm doing the volume up button, it's going back down again. Is there? No, not on Instagram. Sure.
Just volume for you to hear. It's not recorded volume.
That just went off.
Okay.
Yeah.
It's a live show.
I know. Sorry, guys. We're just working with the technical glitches. It might be being pushed.
Oh, yeah. All right, here.
Sorry about that, but is the volume working? I don't know if there's sound or not.
Oh, no, you want it muted.
You do?
Because otherwise...
Okay, perfect. I didn't know if people could hear or not. Sorry about that. Technical glitches. So in any event, tonight's topic is interesting. We're going to be talking about cumulative live birth rates following insemination with donor sperm in single women, same-sex couples, and heterosexual patients. And as always, we'll answer your questions as we go through. But I do want everybody to get a chance to go back and look at last week's show because, like I said, for those of you who are even considering IVF, very, very useful information, something to really spread the word about. If you do 3 genetically normal embryos transferred into the uterus sequentially, so this is not once, one after another, you have a 95.2% chance of a live birth. And that's huge news for everybody. So we want you all to know that. We want you to be very familiar with that information and have the opportunity to use that moving forward as part of your decision making, because it's critical you know what your chances are. And it's also really important for people thinking of doing ERA tests or all of these fancy tests or treatments, because realistically, if you haven't failed 2 or 3 times, there's probably no need to do that stuff unless you have a history of a specific problem, because you can actually avoid having to spend a fortune and go through treatments that may be unnecessary. So keep all that in mind. Really, really important as you go through this. It will be up on our YouTube channel, and hopefully you guys will have a chance to see that. Okay, so hopefully people have
Push mute. You pushed mute.
There you go. I didn't. Maybe the thing hit.
Yeah, we're good.
Yeah. So sorry about that. You should be able to hear us now. Can Facebook folks hear us? Thumbs up if you can hear me on Facebook now. You should be able to. It looks like it's okay. So in any event, let us know if you can't hear us. Yep, it's back. Perfect. Okay.
Your actual lapel mic was muted.
This is muted?
Yeah, push that one more time. Just push it once. Yeah, okay.
Good?
Yeah.
Okay, so they did 13 years. They looked at 8,922 treatments in 3,333 consecutive women. 45% were single, 43 were same-sex, and 12% were heterosexual couples needing donor sperm. Again, it was a single UK center, so the nice thing is they had good control over the studies, and they could look at everything very carefully. So bottom line from all of this is that they had a really robust data set, which is awesome because that helps us with the stats from all of this. And as I was saying, they really wanted to determine how many cycles can you do in a row before you run out of steam, so to speak, and see that you're ending up essentially with the same success rate regardless of how many more times you do it. So the results with all of this were interesting in terms of who they picked. So the patients were relatively healthy, but kind of garden variety everybody. So they said they had a normal basic fertility workup, including general and gynecologic history, infectious screening, and ovarian reserve markers. So these were not women with low AMH or very poor previous history or anything like that. They did have their tubes checked and made sure that they were okay, either on ultrasound or hysterosalpingogram, but it wasn't mandatory in all patients. And they said that if they had failed previous treatments with insemination, they definitely checked to make sure that their tubes were open, or at least it was strongly advised. And then in terms of the treatment, they either offered natural cycle stimulation, which was just your normal cycle, and you tried to do an insemination from that. Clomiphene, they did not have letrozole in the study, or they had insemination following gonadotropin use at a low dose, so just 50 to 75 units either every day or every other day. And for the patients that were spontaneously surging, they received their IUI after 24 hours from the spontaneous surge. And for patients that were using triggers, they had it 36 hours after, which is pretty standard. We do the exact same thing. Their trigger time, if you had 1 to 3 follicles that were more than 17 millimeters, they triggered you. And if you had more than 3 follicles above 15 millimeters, they canceled you. So that's important just because it was the same kind of protocol for everybody. It wasn't like one group was getting 10 eggs and the other group was getting 3 eggs, and they were still going ahead. So the sperm was coming from different sperm banks. In fact, they used a couple from America, most from the UK. The study was done in the UK, as I mentioned. And interestingly, they had a minimum of 5 million sperm inseminated that were progressively motile, meaning you had to have a minimum of at least 5 million moving sperm in the sample. And that's really important because you want to make sure that this is a reasonable sperm sample. So the other important part about this is this does not apply to couples who have very poor sperm quality and then they're also trying to conceive using IUI. This is a relatively uniform cohort with people that have reasonably good outcomes. They don't have poor ovarian reserve. And of course, the sperm is from donors, so the sperm is going to be at least decent and never terrible. Okay, so the important thing here is that we look at the data for this, and I'm going to look over that data with you. As always, we'll share the data with you guys in terms of online for YouTube and Facebook and Twitter, and for my friends on Instagram, which is the majority of folks when they're watching the show. I'm going to kind of explain it all to you. Okay, so the first data point to look at is this one here. So the very first table that they had, essentially they looked at the relationship status, not that it's important, but same-sex couples They had about 11% of the live births, heterosexual around 10%, and single women was a little bit lower at 6.7%, although importantly, the majority of single women, they did say, were older. Overall, they had 795 live births. So the overall success rate, and then again, this is really critical, was 8.9%. So using these low dose stimulations with donor sperm, with the Clomid or the small amounts of gonadotropins or a natural cycle, you're only ending up overall in this huge population of treatment with 8.9% live birth per try. So that's a really important number to know about, because a lot of people come in with these kind of inflated expectations about what they're going to get from IUI. If you're looking for a 70%, a 60%, and 80% success rate, it is not possible to achieve that with IUI. Nowhere even close. You're looking at very modest, humble numbers, in the tens, sometimes as high as 20 if you're going more aggressive, where you're now risking multiples. So 8.9% was the important number. Overall twin rate was 3%, again, very important. And there was only one triplet rate or one triplet case, which is also important to know about. And so that's all critical information. As I mentioned, the live birth rate among single women was lower, but it was because most of them were a bit in the older age group. In terms of the actual rates, if you did a natural cycle, meaning no meds at all, no Clomid, no shots, the live birth rate was 8.5%. And for those who were getting some degree of stimulation, 9.4%. Again, hugely important. You don't have to do pills and shots, and you're getting almost the same success rate. So that is very important to remember. Don't feel forced into spending money on meds. It may not necessarily be important. There is another study actually also just released, which says the opposite. So I always like presenting the counterpoints to this, and says that stimulation does improve things, but again, it's not a huge difference. So from 8% to 9% is about a 10% increase in success. The actual number only represents a 1% increase in success. So remember that as you're looking at all these studies. Okay, so the next data point is right here on this table, and this is really important. So they broke it down by age group. So this is critical for people to understand. So obviously, the older a woman gets, regardless of which relationship category they were in, the lower the success rates get. And it is really, really important to see these. So when you were under 35 and you did a natural cycle, so no meds, 11.3% live birth per cycle. And when you did mild stimulation, 15%. 35 to 37, 9.2% for the natural, 10.5% for the mild stim. When you're 38 to 39, you're now getting down to 8.3% for the natural and 8.2% for the mild stim. 40 to 42, your rates drop in half. So you're now down to 4.1%, still 6.7% for the mild stim. When you're 43 and over, they had very few numbers in the natural, 1 out of 300 patients, almost 299. So there was 0.3% is what that translates into. Obviously not a strong number. And even in the mild stim, which was 2 out of 376, it was only 0.5%. So very, very low yield if the patient is older, unfortunately. And you need to remember that, because if the patient is older, unfortunately, that's not quite the same result, and you need to warn them of that. Here's what is really critical about this. There's this lovely little graph, and I will share this with the Instagram folks as well. You can see it right there, and I've kind of hashed it out with the green mark. So those green marks are important because that tells you where the cutoff was, where the success rate started to plateau. So if you look at the red line, which is the top line on YouTube or Facebook, you can see that once you did 6 cycles, there really was very minimal, if any, increase. And statistically, they said there wasn't any beyond 6 cycles for those who are over less than 35, 35 to 37, and 38 to 39. Once you've hit 6 cycles for that age group, you're not getting an increase in your success. In other words, you should stop doing this if you've hit 6 cycles. And realistically, even approaching 6, you're really seeing a very small change. So even in the less than 35 group, you're going from like 25%, 27% at 4 cycles to that maximum of just under 30% when you're getting up into the high number, like 11, 12 cycles that they had done. So very, very important info, because if you're doing lots and lots of cycles, you're not actually helping the patients. Beyond a certain point, you're actually wasting your time, because you're talking about 1% incremental changes. And that's really not justified financially. It's not justified medically. The patients need to be told that this is not helpful to them any further. The important part, even more so, is the age group that's 40 to 42. So if you look at this age group down here, you can see that pretty much after you've done 2 or even 3 cycles, you're starting to plateau. So in that age group, there is really no benefit to getting the patients to do more cycles. They're actually not going to benefit at all. So if you're over 40 years of age, basically after you've done 2 IUI cycles, maximum 3, and even then you're kind of pushing your luck, you're really looking at 1 or 2% increases in success beyond that up until 4 cycles. And at that stage, you're really seeing no increase. So realistically, 2 cycles, maximum 3, and you need to move on. So this is really, really critical information, because this did not exist before for us. And we need to know this in order to help patients see what they should do and how they should do it. So critical info, when you're doing this yourselves, granted this was with donor sperm, but if you fall into that same category where it's something relatively minor, you're either unexplained, or it's like really mild male factor, or it's a cervical stenosis problem, or you're just anovulatory, and you're going through the insemination process, if you're going to a center which is telling you to do this over and over and over again, then you need to stop, because that center is not helping you. They're actually just trying to make money, and there's no benefit. And one might say, well, I can't afford IVF, at least let me try. Well, you're welcome to try, but understand that for each try you're doing beyond 6 tries, you're actually not gaining any benefit. It's not that it's going to be an additional 8% or 10% or 15% or whatever they quote you each time. You're actually getting no difference at all. You've capped or topped out your success level, and because of that, there's no benefit to going on. They do reference some other cycles or other studies, I should say, and I do want to mention one that they talk about that I'll probably look up. And that's a study where it was done out of Denmark, and they looked at 12,488 patients who started with IUI, and they said that they went up to a maximum of 3 attempts. So in that group, similarly, 34.2% were able to get pregnant within 2 years of trying, 38% went on to try IVF, and 16.6% got pregnant completely on their own. So again, it is important to remember that there are people who will try this stuff, it won't work, and then they'll go on and get pregnant on their own. Many patients will need to go on to IVF, and it's important to acknowledge that that's a possibility. And at the same time, it's also really important to note that inevitably some patients will get pregnant from the IUI and they won't need any other treatment, but you need to know where those limits are, and those limits appear to be age sensitive. So greater than 40, don't do more than 2 or 3 cycles. Less than 40, maximum of 6. We usually tell patients even after 3, we want to try something different. And that might be moving from natural to pills, or moving from pills to shots, or from natural to shots. But we try to do something different to improve their chances. Simply doing this to patients over and over and over again is a waste of time and should not be something that we're doing for people. So is it a fact or fiction that there is a limit to the number of IUI? It is a fact. Doing more than 6 for patients that are younger is not of use, and doing more than 3 for patients that are over 40 is also not of use. You're basically doing nothing of value for those patients, charging them hard-earned money and returning nothing in return. So thanks for joining us for the fertility fact or fiction part. We're going to jump into our questions now. I'll stop sharing the screen, and certainly if you have any questions about the article, don't hesitate. We're always happy to answer those questions. I'll start. You can grab the thing if you think there's any pre's, and I'll do it up here. It's all on here? Yeah? Okay. So I have to give a quick shout out to Tarek, who dived in last week because our building alarm went off. and he was me momentarily. Apparently, he got some fame because someone recognized him and told him he was famous. So, Tarek, thank you for being famous briefly last week. So Marianne is asking, if an embryo implants on the uterus location where previous retained placenta was removed, would that impact the transfer success? Marianne, I thought we answered this last week. Let me see if I can show that on the screen. So the question is, if your embryo goes and implants in a location where there was placental adherence from a previous pregnancy or miscarriage, could that impact the success? Probably not. It may affect the placentation, meaning how the placenta attaches, because there can be abnormal placentas that stick so hard to the uterus they don't actually come off. And in those cases, we do sometimes need to even do a hysterectomy, God forbid, but sometimes it's necessary because you can't detach the placenta. But overall, there should not be a significant impact from the embryo implanting where a placenta previously did. And certainly depending on the size of the placenta, if it's an average placenta, they're pretty big. I mean, anywhere from sort of a minimum of 6-7 inches wide in diameter to maybe 10 or even 12 if it's a really huge placenta. So that takes up a lot of space in the uterus. There's no way to control that much where an embryo is going. In particular, embryos always go on the back of the uterus unless the uterus is completely retroverted, retroflexed, and 85% of placentas are on the back. So it's pretty common to probably have embryos end up where placentas were. Ashley Graham, good evening. Hope all is well. I see you're still alive after that message with the wife. When should a double line show on a pregnancy test at home? So we're trying to come up with a video on that. We have it half done. We need pee from women that are pregnant only 8 days into it. So the tests claim that they can detect within 8 days. And we read it, and the sensitivity is only about 30% at that 8-day mark. So realistically, most of the tests are pretty accurate out at about 11 days after ovulation. Prior to 11 days, it's probably going to be a little more shady, but realistically at 11 days after you've ovulated, which should just be a few days before your period would normally occur, you should be able to test with a home pregnancy test and get the double line. New messages. Let's check out a few more. Dr. V, did you ever confirm if taking CQ10 is okay with blood thinner injections? Yes, I looked into that, and we can't find anything that says that it's a problem. So you should be okay between your CQ10 and your blood thinner. Obviously, talk to the pharmacy you go to. I could not find anything that talked about that being an issue. Okay, let's go to Instagram and ask some questions from here. Well, a lot of people have joined us here. So, someone's commenting that I suited up. I actually like dressing up, but I don't always get a chance to because sometimes I'm doing procedures. So thank you for noticing. What would cause an endometrial polyp after my labor? Is it possible I had this polyp during my pregnancy? If it was immediately after your labor, Marianne, it's definitely something that was there already. If it was a month or two, it's impossible to know. It could have occurred afterwards. In general, in a young, healthy woman, a polyp is nothing to worry about, so we don't get concerned about those. But it's something to be aware of, and sometimes it helps to have them removed. Certainly, if you're trying to get pregnant and you have a polyp, you definitely want those out because it increases miscarriage rates and decreases success rates for sure. Do you subscribe, I think you mean prescribe, aspirin to your patients before their transfer? And if yes, do you have them continue taking aspirin if pregnant? Yeah, so we have a fact or fiction on aspirin from last November. It was a year ago. Yeah, it was a while back. So aspirin is definitely beneficial in fertility. There's no question. And so we have almost all of our patients on aspirin. So yes, we do it prior to the transfer and throughout the whole pregnancy. There are multiple benefits. Reduction in preeclampsia, reduction in preterm birth, and probably an increase in success rate. So we do use it. I love using aspirin. And with rare exception, there is no downside. Do I prescribe DHEA for the over 40s with a history of PST IVF failures due to poor embryo quality? If so, what dose? DHEA helps make more eggs. That's been proven several times, but it's also been proven that it does not improve live birth. So while I may use it occasionally to help patients, I don't actually think it makes a difference ultimately, because there are multiple studies demonstrating it does not improve your live birth rate. So that's not actually going to help you. I definitely want people to maximize their egg number, but even there, it's not making a huge difference. If you're making 3 eggs, you might make 4. It's not like all of a sudden you're going to make 10 because you were on DHEA. So it's something I discuss with patients, and we'll certainly offer it to the ones that aren't doing well. To be honest, testosterone for a shorter period of time than DHEA is necessary, because we normally give DHEA for 3 months. You can use testosterone for just a couple of weeks. Has the same effect and may actually increase live birth. So we typically will use the testosterone rather than the DHEA nowadays. But I would, generally speaking, kind of have these discussions with my patients, because I want you involved when we're deciding what to do and make sure that you're part of the decision process. When your patient has had a successful first transfer, do you use that same transfer prep protocol in terms of progesterone and estrogen for their subsequent pregnancies? Rule number 1 of good medicine: if it ain't broke, don't fix it. So yes, unless we're adding something harmless in. For example, there's new data that shows that iron levels are important to getting pregnant. The fish oils are probably helpful, vitamin D and so on. So the harmless stuff we will add, but from the estrogen progesterone standpoint, we'll frequently go back to doing what worked before. Do I have an update on doing retrievals at the Windsor Clinic? I just got an email from the college. They want a few things that we've actually already given them, which left me a little confused. But they said they're going to be asking the reviewing group to let us know when. I suspect it'll be very, very soon. And we've already given them everything they need except for 1 or 2 things. And that'll be going tomorrow. Kimmy, if you're watching, I need you to do something for me tomorrow. Okay. For women with PCOS, this is from Nicole, could milk production when not breastfeeding and not pregnant be a symptom? So I think you're asking, if you have PCOS and you're still producing breast milk, is that a symptom of the PCOS? And the answer is no, that's a symptom of hyperprolactinemia, and you need to be tested for that. So Nick, come on in and we will test you and make sure that your prolactin level is not high. Now, if it's within 6 weeks, 2 months of when you stopped breastfeeding, it may still be elevated. And you can still get some milk production, but if it's been more than that, then it's important for us to take a look and make sure it's not elevated in your pituitary gland, which is kind of right in there. But further back, you produce prolactin. Prolactin causes breast milk production, and in some women, the gland gets enlarged, not in a harmful, cancerous way or anything. Frequently, and that enlargement can actually cause the overproduction of prolactin, so we can treat it with some pills, and that's important for your fertility, so definitely we can take care of that. How can vitamin D or iron deficiency affect transfer success? What should vitamin D and iron levels be to rule out deficiency impact on transfer? So there are normal levels depending on which measure you're using. Vitamin D, we like over 75, preferably even over 100. With our units, and iron ferritin is what we're looking at. So a normal ferritin level is like at least over 60 in a non-pregnant woman, so you want it to be at least over 60. Still waiting for surgery. Are we getting closer? Kelly, you ask that every time, and the answer is we are getting closer because they're giving us more surgery time. Unfortunately, because of COVID, it's still a long wait, so hang in there. Okay, Tardy 3. I'm 36 and haven't had issues with poor egg reserve or low AMH. Will I get benefits from taking ubiquinol, or is it only for those with low AMH? So ubiquinol is believed to work by impacting the function of the mitochondria in the egg. And mitochondria are essentially the energy source for egg function. So the better your energy source, regardless of your age, most likely the better the embryo quality. We don't have data for that, but biologically it just makes sense. So it's certainly not going to harm you. Is it going to help you? We don't know for sure, but I would take it because it's not going to do anything bad. And at worst, it'll help or do nothing. So, ubiquinol is not very expensive. It's worth taking regardless. I would definitely take that. Do I mean 3 IUIs? I do mean 3 IUIs. Nevra, age 44, trying natural conception now. Can I use estrogen pills and progesterone shots and blood thinning shots similar to the transfers I had previously? I still have lots of meds from my previous IVF. So, yes, no, yes, and kind of. So estrogen, if you take before the right time, will actually prevent you from releasing an egg. So that would be a big mistake. Progesterone, if you take it the wrong time, can prevent you completely from getting pregnant. It's birth control if you take it at the right time. So if you take it at the right time, it's okay. But if you take it at the wrong time, it's birth control. Blood thinning shots, if you need it, you can take. We don't normally do that in a natural conception pregnancy. It's not harmful other than the bruising and the pain, but it's not indicated necessarily. A lot of people would actually argue it's not even indicated in fertility pregnancies. So keep that in mind when you're choosing that stuff. Sorry, I meant to say if you are over 40, should you stop at 3 IUI in a row, or does it matter the timing that it is done? If you're over 40 and you're doing more than 3 IUI, the study we just reviewed is demonstrating you should stop because there is no benefit to doing more IUI. You can move to IVF, and it's actually saying you should, but you should not continue doing just the IUI because you're wasting your time and your money, and we don't want to waste your time or your money. I'm still getting that same question about the IVF, about the embryo transfer into the same spot. So Vicky, I answered the question about what would happen if you implanted your embryo over the site where the placenta previously was. Where was the triplet case recorded? It was in the UK. The whole study was from the UK. I emailed in to get a consultation, but need a new referral, even though I'm at a clinic now. I can't get in to see my doctors for months. Walk-in clinic. You can come in without a referral, but you're not supposed to. So the easiest way to do it is to go to a walk-in clinic and just say, I want to be referred to Dr. Victory. It's the easiest money the walk-in clinic will ever make. If you absolutely can't get through, message me on Instagram and we will figure things out, but you should be able to do it through a walk-in clinic, no problem. info@drvictory.com to contact us, or our fax number 519-944-6406. Can you get IVF covered after having your tubes removed? You can. So the new Ontario program has no restrictions on any history whatsoever. As long as your age is less than 43, you can get funded IVF, if you can get funded IVF, because it's super hard to do so. Do I need a referral from a physician to have a consult with you, or can I self-refer? So similar to the last question. You can self-refer if you're coming for IVF for a private service. And that is kind of a backdoor. So you can say you're coming for IVF. If you change your mind afterwards, that's fine. We do have to charge you for the referral, and I apologize for that, but it is possible to do so. Dr. Victory and his staff gave me my babies in capitals. They rock. I'm gonna show that one. That's cute. Thank you. We love you, and we love your babies too. Very cute. I've heard that you are out of funding for IUI monitoring until April. Is this true? In the Windsor location, it's very true. We have some funding that our Sarnia clinic has allocated for Windsor that they haven't used all of. So we just got that recently. We've got some cycles that we can use so we can monitor you here. You just have to go to Sarnia for the IUI. That is the best we can do right now. We are fighting with the government for more. Tell your MPPs, please, please, please tell them. How many days after an embryo transfer do you suggest patients test at home on a pregnancy test? I don't. Wait for the test that's being scheduled. You will drive yourself crazy with home tests. So just wait. And thank you for saying I rock. I appreciate that. You guys are too good to me. This show is fun for me. Tarek and I have a good time doing this. We've become pre-game food connoisseurs. We love eating before the show. And we have a great chat every time. And then we get to help people. So this is like great for us. Can you continue to take supplements like inositol-NAC and CoQ10 when starting meds for an FET cycle? Yes, you can, and you probably should. So stay on those supplements when you're going through it. Does DHEA improve egg quality or just number? Absolutely no evidence to demonstrate that DHEA has any impact on egg quality. It is just egg number. And that's been shown in multiple studies. Is 2.5 milligrams of letrozole standard for an initial IUI cycle? And if no success follicle growth, would dosage be doubled or tripled or person dependent? That's a great question. So we actually gave up on the 2.5 because not as many people as I would like were responding. So we start at 5, and then you go up to 7.5, and then you max out at 10. If you're getting to 10 and you're not ovulating, you need to take a different medication. The letrozole is not working for you, so make sure that you are using a dose that works for you. We have a great flowchart on our website under the resources guide, which shows you exactly how to go through your letrozole dosing. So www.drvictory.com. There's a resources guide tab. Click on that, go down to the letrozole flowchart, and it blows it up into this nice big picture you guys can see. For someone who has had a prior ablation, what is it you would take to help lining afterwards to help pregnancy? Even if the current pregnancy isn't viable, is there anything for future pregnancy? Amy, if you have had, or someone you know has had, a previous endometrial ablation, it is extremely difficult to make the uterus respond appropriately. Is it possible? Yes, but I've seen not so pleasant things happen in that circumstance. I would personally highly advise that you consider exploring the possibility of using a surrogate, unless your lining is really very normal looking, both on ultrasound, saline infusion sonohysterogram, and even doing a hysteroscopy. And then I'd want to check for infection in the lining using the Fertility company that we've talked about on the show before. Do not jump right into fertility or IVF or anything like that after an endometrial ablation. It is very, very difficult to make that work. Very, very difficult. Hi, doctor. Do I see patients in Toronto? I do. I see patients in Toronto, and we are going to announce shortly some really interesting, exciting news, which should actually be finalized tonight. So I'll let you know about our Toronto clinic very, very shortly, but we'll be in Toronto regularly coming up soon, and you'll be able to see us there. So we're really excited about that. Okay, YouTube. Live, love, fearless. What can I expect for an HSG test? Have one coming up in the next week or two and feeling a bit nervous. Okay, so if you're going for your HSG test, first of all, take ibuprofen before you go. Make sure you tell them to be very gentle and to flush very, very slowly. HSG tests do not have to be painful, although they frequently are because the oil is very viscous and it's an oil-based contrast. And because it's oil-based, it's harder to get it to flow through, so you have to push harder with the syringe. Don't let them push too hard. It will hurt if they do. To be honest with you, my advice would actually be avoid a hysterosalpingogram if you can. You really should just be having a saline infusion sonohysterogram. HSGs provide you no information above what a SIS can, unless they couldn't see your tubes clearly enough on the saline infusion sonohysterogram, which for us is rare. It's only about 5 to 7% of the time. So most of the time we can see your tubes being open on the saline infusion sonohysterogram, and no one ever complains. I had a patient we did it on today with our amazing nurse, Lisa. And the patient said her friend told her someone needed to come and pick her up, and it was horrible, and she couldn't work that day. And when I was finished, she goes, "You're done?" And I said, "Yeah." She goes, "I didn't feel anything." And I said, "Right." So we have a great video from one of our amazing patients who we love dearly at our clinic. And she's done the video for us. She's actually currently pregnant. And that patient did the the saline fusion sonohysterogram, and we videoed it. And the whole time I'm saying, "Do you feel anything?" And she says no. So, it doesn't have to be painful. Warmed fluid, super gentle application. Don't force it through. Talk to the patient about everything you're doing as you're doing it. Most patients have a perfectly reasonable experience. I was told to take progesterone for my next pregnancy. How would you know when to take it? I know if taken at the wrong time, it will be like birth control. Right, so I just said that earlier. So this is from YouTube again, Jazzy Nixie. So Jazzy, you need to take it 2 days after your ovulation predictor kit is positive, or the day after you've done an insemination. So follow through with that, but essentially it's 2 days after your ovulation kit. And that's the normal marker for us if you're doing it during a natural cycle. And so use an ovulation predictor kit, use it in the morning. The day you see it's positive, not the next day, but the day after the next day is when you would start your progesterone. Make sure you take your progesterone vaginally. It is not useful to do it orally. The bioabsorption of progesterone orally is poor. We only use it in circumstances where patients can't tolerate it vaginally or intramuscularly. Kim Zamani. Hey, Kim. God, I hope you're not still watching, man. It's late in the night for you. Kim is a good friend of ours in Spain, so hello there. Can you donate blood while doing fertility treatments? Oh, that's a good question. I've never thought of that. I really want to donate due to the short supply of donations, but am worried it will affect my current treatments. I wouldn't. So it does alter your physiology a fair bit when you donate blood. You're going to use a lot of your body's energy to produce new blood. That's going to definitely rob energy and function away from other organs that are less important during that time, like your uterus and your ovaries. So I would avoid that, Nick. How long is the wait time to get an appointment after a doctor referral? To see us, usually within a couple of months. It's pretty quick. If there's an urgency for any reason, indicate that on your referral, and our office administrator will make a decision or bring it to my attention. If there's desperation, it's a cancer case or something like that, I see those patients the same day every time. So we try and accommodate people as quickly as possible. I do work 24/7. We will all need to apply to God for more time if you want me to see more patients. Do you recommend pre-seed to help with conception? Yeah. Don't use saliva. It's chock full of bacteria, and all of the other ones are not quite as good. So pre-seed's very reasonable. It has at least been shown to have the least impact on sperm quality. So pre-seed, if you don't know, guys, is a lubricant. So use it to help you. And it's actually a reasonable lubricant. How can some couples get pregnant so easily? Sorry, it might be a stupid question, but can people be that fertile? Yes, people can be that fertile. Some people can get pregnant on an oops one time, and other people struggle for years and years and years, and it doesn't work. So how come? It's not a stupid question. It's a great question. It would take a lifetime to answer, though. There are so many different factors that go into how people get pregnant. So that's a tough one to answer. Is Sarnia at risk of running out of funded IUI spots? No, we still have plenty of funded IUI in Sarnia. How long is your wait list for funded IVF at your Sarnia clinic? It's long, unfortunately. We do not have funding dedicated for either of our clinics. I have to get what I can by taking private patients to a different center and then using that. We are trying very hard to get funding from the government. Let your MPPs know they're the ones that will make the difference. And you're welcome for recording these videos. What can you take to improve egg quality? So there's two parts to that. If you're talking about your egg genetics, nothing, because it is what it is. If you're talking about the rest of the function of the egg, vitamins. So there's kind of three branches to it. So number one, there's the supplements and vitamins you can take. Number two is healthy diet and exercise. And number three is avoid the bad stuff. So vitamins, vitamin D, coenzyme Q10, the fish oils, any of the antioxidant vitamins, your prenatal and iron. You should be on all of those. And supposedly melatonin helps get pregnant as well. So all of those would be really, really important for you to take. And we recommend those to all of our patients. In terms of the supplements and exercise, NAC and inositol, especially if you have PCOS, can help as well. And again, coenzyme Q10. Diet, they say the Mediterranean diet is best. So lots of fresh vegetables, fresh fruits, fish, avoid red meats, avoid foods that are rich in fat or in carbohydrates. And exercise daily. Even a small amount of weight change can make a big difference in the success rate, the time to getting pregnant, all of that is impacted. And then lastly, avoid bad stuff. No smoking is okay, including hookah for those of us in the Windsor area where everybody's on the hookah. Make sure that you're not drinking at all. No amount of alcohol is good. Alcohol is a class 1 carcinogen. Sorry if I'm harming your weekend fun, but it is not healthy for you. And number three, absolutely no drug use. Even a minimal amount of marijuana is a disaster for your fertility. So don't think it's safe. It is not. Avoid that completely. Do I have a preference between Gonal-F and Puregon? 100%. I use Gonal-F. It seems to be stronger and we prefer it, but there's one and only one advantage to Puregon, and that's that in every 300 unit pen of Puregon, there's actually 400 units, so you're getting 25% more for free. So for patients that can't afford it, we do use that. What is inositol used for? Don't think I'm taking that vitamin. So it's a supplement. It's not a vitamin. It's used for reducing inflammation, and it's very good in PCOS women. It's been proven to be beneficial there. Can you continue to take supplements? Yep, somebody asked that. I answered that already. Have you heard anything from the government if partners can soon be allowed to be present for fertility patients? That's not a governmental issue. That's a clinic-to-clinic issue. And each of us is doing something different. For us, if you screen negative and you're wearing a mask, we allow you to come in for an embryo transfer, but not for monitoring. It's just not worth the risk for something you're coming in for multiple times. But for the one time you're going to come in for an embryo transfer, we want that to be as calm and as relaxed as possible. Facebook. What is the best part of your job? What is the worst? Best part of my job, helping all of you. I love getting to do what I do. I will say that I love my surgical part of my job as well. But I love getting to help people. I mean, what could be cooler than getting paid to put smiles on faces? It's literally like the ultimate high. What is the worst part of my job? The worst part of my job is when it doesn't work and patients give up. It's hard for me because I feel like I failed them, even if it was just biology, and I never want to fail. I always want to succeed for you guys. So I'm willing to keep going and fight and push, but there are biological limitations, there are financial limitations. Sometimes it's ethical, moral limitations. Some religions don't allow certain treatments. And so it's hard for me when I can't help people. That is difficult. So that's the toughest part. Great question. No one's ever asked me what the worst part is.
Worst part, never heard.
Yeah. Okay. I am in the US and seeing so many women going through fertility treatments with REs, and these women are resulting with low progesterone and early blood testing and being told by their REs they don't believe in progesterone and that if their levels are low, that the pregnancy is just not viable and should just wait to be miscarried. Do you have any insight as to why this may be or why REs would be practicing this way? My insight would be that makes no sense. So if the progesterone level is low, then the REs should definitely be dealing with that. And we support all of our fertility patients with progesterone therapy. So I think that is super, super important. You should be following through on that. I don't know why any RE would not be a believer in progesterone. In a natural cycle, if you're just monitoring someone's progesterone, at the start of the cycle, there should be virtually none. It's not until you've released your egg. So you do get some places that monitor progesterone right from the beginning of the cycle. That's a very good way to make us rich. It's useless for management of your care. So it kind of depends on what exactly you're asking, but we support all our patients with progesterone. The data, however, on this is equivocal in that there is no really good data that progesterone prevents miscarriages. However, all of the studies have involved using progesterone very late into the pregnancy, not right from 2 days after ovulation, like I think it should be, or the day after ovulation. You got to click your button. Oops. Okay, thank you so much for doing these. You're so informative while still talking at a level that I understand. Your personality and compassion is hard to find in this field. Thank you so much. Well, thank you for saying so. That's very sweet of you. Okay, we're winding down, 8:51. Why would my wife need to do Fertility? Can't she just do those blood tests at your clinic? So Fertility is a test to tell patients that they have certain bacteria in their uterus. If you have bacteria in your uterus, that won't show up on a blood test. In fact, it won't even show up as any kind of infection anywhere. It can kind of be hanging around quietly, biding its time, waiting to cause a problem. Without doing RNA testing, which is what Fertility is, there is no way to know if there is bacteria in the uterus or not. So great question, but there's no way to know without actually doing that test. Just had our first IUI in your office with trigger shot, ovulated rather late though, day 19. Do you think this will be detrimental to our success? No, day 19 is still okay. It's the ones that go really, really long, 19, 20, 21, where we start getting worried about it. I'm still okay up to day 18, 19, but when it starts going past like day 21, 22, 23, we start getting concerned. So if you trigger it on day 19, you're probably still fine. That is kind of on the outer limit. Had 3 PGTA embryos. First FET failed. Listened to 95.2% live birth rate with 3 PGTA embryos. We want 2 children. Do you recommend another retrieval stim cycle instead of another FET? Oh, good question. So this patient is saying they've had 3 genetically normal embryos, but they want 2 kids. Should they do a whole new IVF cycle before transferring their 2 remaining genetically normal, because they may need both in order to achieve at least 1 baby and they need more for another? So easy to answer. Depends on your age and how strong your ovaries are and your finances. I mean, banking embryos is always a great thing if you can afford to do it. If you can't afford to do it, then don't. I mean, I would go with the embryos you have. I never want anybody to go into debt to do IVF. So I warn everybody, in fact, strongly against that. So if you're insured for it, if you're covered for it, if you're in a state where it's mandated, that kind of thing, then yes, absolutely, do it again and again and bank a bunch of embryos. And that's the best idea, because the younger you are, the higher your success rate. But if you are paying for this out of pocket, money's tight, you're going to have to borrow, that kind of thing, then I would just go ahead and try and get pregnant first, because there may be more to your story than just those 2 embryos, right? We may have to still find that you're not in that 95%, God forbid. And if that's the case, you want to know what's going on before you start making more embryos so that we can make sure everything's okay. My doctor does not believe in progesterone either and does not want to monitor my levels once pregnant. So once you're pregnant, it's not important to monitor your progesterone levels. I did, however, get him to agree for me to take suppositories until week 10. Don't monitor your progesterone levels after just the first couple of days. It should stabilize at that point. So you don't need to monitor progesterone levels through the pregnancy. It fluctuates way too much. So don't bother with that. Just take the progesterone and you'll get a high enough level. Michelle Bell had a very nice comment. Thank you, Mish. I love you. You're a sweetheart. Okay. What's next? What about for endo? Does inositol help? I haven't seen any specific studies on endo and inositol, so I plead ignorance on that one. However, inositol is a good anti-inflammatory, and endo is inflammatory, so it should help, and it certainly won't hurt. So I would definitely try that. We have a telephone consultation with you soon. Is it possible to have that in person? Yeah, we can do it in person if you want to come in. Although, in order to save everyone from the effects of COVID, we try and do as many as possible by phone. So if you guys can manage to do it by phone, that's better for everybody involved. But if you really want to be here, that's fine. Nevra is asking if she can be in our video live. And the answer is we don't do that because we're on multiple formats. Maybe we'll start doing some Instagram only soon. We're going to have a Victory University. So we're going to call it Victory U or Infertility U soon. So we're going to get people to sign up. And we're going to kind of go through each topic with a smaller group of patients so they can get all their questions answered because we are missing some people. How much iron should I be taking if trying to conceive? That's easy. So take either Palifer or Ferromax. They're my two favorites. Triferrix is good too. You want one that's glycosylated, which means that various sugar is attached to the iron molecule. And those glycosylated sugar pills are Triferrix, Ferromax, Palifer, 1 pill a day. They vary in their dosages, but most of them have about 150 milligrams of elemental iron, which is a lot, and that's what you want. You want a lot. Okay, Nicole C. Last question for tonight, LOL. What are the success rates for women with amenorrhea? Nicole, depends on amenorrhea due to what. If it's amenorrhea due to menopause, they're terrible. If it's amenorrhea due to PCOS, they're extremely high. So it just depends on why you have the amenorrhea. Even if it's for a few years, that won't make a difference. Hello, doctor. I had a hysteroscopy to remove polyps, and they sent it out to pathology, and the results came back as hyperplasia without atypia. Okay. So Zaina, you need to find out why you have hyperplasia. Is it weight related, anovulation related? You were exposed to too much estrogen, just bad luck. And then you need to take high dose progesterone for 3 months, and then it should go back to normal. As long as there's no atypia, the risk of cancer is low, especially if it's simple hyperplasia. If it's complex hyperplasia, it's a little bit higher. It's 8% chance of progression to cancer. Sorry, it's a 3% chance of progression to cancer. So you need to be careful. But as long as you take megestrol acetate, which is a very strong progesterone, you should be good. But it's very important to make sure you start ovulating regularly if that was the reason that you were not, that you developed the hyperplasia, or to figure out what you were being exposed to that caused the hyperplasia. For those of you, including Nicole, who's asking about the amenorrhea for years with PCOS, it is 100% not safe, I say this every show, to go through life having irregular periods. You cannot do that. You must be regular or be on birth control to protect you. Otherwise, you will end up with hyperplasia, and God forbid your hyperplasia will become cancer. So you absolutely cannot go through life for years at a time not having regular periods. That is not safe. Never says she didn't request a live video. No problem, Nevra. Casey, laparoscopy or IUI for unexplained infertility. Already had clear HSG and salient ultrasound, secondary infertility. So the guidelines would say IUI with pills, IUI with shots, or IVF. They don't talk about surgery, but I'm a believer in doing surgery for patients where it seems to be indicated, especially if you're about to jump into IVF, and especially in Canada. Surgery in Canada is free. So if you're going to do IVF and you have to pay out of pocket for it, you can't get government funding because of the ridiculous wait list. It makes sense to go for surgery. If we find endo, I have literally lost track of how many of our patients got pregnant from endometriosis surgery, just because I clean it up and then they don't even need us. They get pregnant on their own. I just saw a patient again today who is pregnant right now. She had a couple of years of infertility. We saw her. we did surgery and she got pregnant. Oh, we cut off on Instagram.
9 o'clock.
Oh, it's 9 o'clock. Okay, folks. My Instagram friends, if you're somehow double watching, have a great evening. One last question for Josh. Hi from Australia. Wow. Thank you so much for these videos. My partner and I are currently on our second round of frozen transfer, and the information provided is very helpful. Well, thank you from Australia. We've actually had a lot of Australians reach out to us, so hello from down under, or from up over, I guess. And I have a brother-in-law that lives in Australia. We were supposed to come out there in a month and a half, and that is now officially kiboshed because of this nasty virus. Okay, one last really quick one. Hello, Dr. Victory. I just had a phone consult with you. You suggested me medroxyprogesterone to bring my period, but I'm really feeling very sick. Today is the 4th day and I can't take it anymore. I'm having palpitations, nausea, and insomnia. Samia, call the office and we'll figure it out. You should probably take a pregnancy test. There's no reason why progesterone will cause any of those symptoms. We can give it to you vaginally. Nicole, last question for you. Is ovarian drilling still common? No one should be doing ovarian drilling unless you cannot even afford the medication for PCOS. It's harmful to the ovaries, it's damaging to the ovaries, and it only lasts 6 months and causes scarring. So do not do ovarian drilling. Okay, guys, end of fact or fiction, or my wife will kill me. She's already going to kill me for my post tonight. So check out our Instagram post. I had a funny post today. So it was great spending time with you all. We look forward to seeing you again. Tune in next week. I'll pick another cool topic we can review and bring all your questions. Signing out. Take care, guys. Have a great night.